Hi, this is Dr. Michelle O'Donoghue from Medscape. Joining me today is Dr. Dylan Steen from Cincinnati, and we're at ACC 2022, which is my first conference post-pandemic, or still, I suppose we're still in the pandemic. But one of the more interesting trials that's going to be presented will be presented by Dylan, looking at basically a supermarket type of strategy towards better eating. And this is a topic that's near and dear to my heart because I think that diet and diet interventions are often overlooked in cardiology and actually can be a path forward for many patients in terms of both their quality of life, but also making meaningful health impacts. So Dylan, why don't we start off with what this trial was about and how you got it up and going?
Sure. And nice to see you again after all this time. So I guess I'd sort of start with, for decades now, we've had research collaborations between the pharmaceutical, biotech, and medical device industry and independent academic investigators. In fact, here at ACC, we're going to see many of these studies presented. But what has been absent are really research collaborations with other industries. And in this case, we actually partnered with the Kroger Company, the largest supermarket chain in the US, who also have over 2,200 pharmacies and over 225 retail clinics. And we asked the question of, could we solve major gaps in the public's adherence to guideline-recommended quality diets by delivering care right in their communities through these supermarkets?
Yeah, and we can have obviously whole separate conversations about what the best diet is to follow. But I think that here it's just really interesting in this era of pharma-sponsored trials to now have a grocery store-sponsored trial.
Sure, and you can imagine, I mean, the retail industry is global. And it sits right in the fabric of every community there. And most retailers now are not just retailers, but sort of retail tech hybrids. So the possibilities to really deliver care that's consumer-concentric, accessible, and convenient is enormous.
So what was the study design for this particular program?
So this was a randomized, active control, parallel efficacy trial. There were 3 separate arms. The control arm basically received an enhanced medical nutrition therapy session focused on the DASH diet, which we all know really works for cardiovascular health. And that was actually guided by data, that specific arm. So a bit of an enhanced version. And then there were 2 intervention arms. So the first intervention arm we call Strategy 1 was basically participants were brought back for 6 additional sessions, and they were guided in each educational session by their own purchasing data, which we took and refined into sophisticated analytics so the participant and the dietitian could understand what to do next and really individualize care. Then they were taken into the aisles of the store to learn how to shop better, how to read food labels, and how to make smarter decisions. The third arm was simply the same as the second arm, except we added online enhancements. So we actually introduced and taught the participants how to shop online, how to get home delivery, how to use various nutrition apps for meal planning, recipe building, and making healthier purchases. So 3 arms in total, each with an intensity that was sort of a little bit higher than the other.
And I think that the third arm is particularly interesting for communities that might not have great access to grocery stores, because the topic of food deserts has been a big one, and we know that certain groups have less access to the kind of grocery stores and the healthy food choices that we're hoping that they will make.
Sure, and you and I, we see heart failure patients, we see patients who are disabled from coronary artery disease. These patients cannot go to the in-store environment and carry their groceries home. So what we call the silver surfer is developing, and this may be the way that we can actually get our patients the kinds of foods they need to stay out of the hospital, to eat those low sodium diets to keep them out of heart failure, whereas really right now they have no other alternatives without using these technologies.
And the reality is, too, that as cardiologists, we know that we're supposed to be talking about diet to our patients, but ultimately there's a lot of confusion, but not just that there's a limit in terms of how much time any cardiologist has in their outpatient practice to sit down with their patients and really walk through what they need to be doing. And we're not always using nutritionists, but I think, as you pointed out yourself, our patients who have advanced cardiac disease might not be able to physically get to the grocery store. And what are we doing to really help them?
Right. I mean, my analogy always is, you want to learn how to swim, you got to get in the pool. And what we're doing is taking patients right to where they make their food-related decisions, not just for themselves, but for their families. And if you think about this, this could be spun off in so many different ways. not just the DASH diet, but the Mediterranean diet for people who have specific medical conditions like celiac disease, for people who have specific allergies, or people want to improve the nutrition of their children. Again, childhood health problems, especially obesity, metabolic disease, are on the rise. This could be a way to get at that as well.
And so what did you find? What were the results of the trial?
So the first thing was that each of the three groups, even the enhanced standard of care, had significant increases in their DASH score, which is a measure of adherence to the DASH diet. So if the score goes up, that means adherence went up. It's something we want. So all three went up, not just at 3 months, but at 6 months. So that is really, really remarkable after just a 6-session intervention. Between group differences in terms of the in-store purchasing guiding strategies did seem to improve DASH score compared to the enhanced control. So that was one finding at 3 months. Also, it looked like the online enhancements did improve DASH diet compared to not having online enhancements. Now at 6 months, the between the group differences became non-significant, but it's worth noting that all three groups still did have improved DASH scores over their baseline when they first entered the trial 3 months after they had finished the intervention.
Yeah, and I think it's just really interesting what an impact it can have. So ultimately, I think that maybe the people who are listening to this are wondering, well, how do we possibly pay for this practically with our patients? So is the hope that insurers actually would start picking up the cost for, more intense dietary interventions, and whether it's through being able to help with online purchases or something along those lines? Where do we go from here?
Yeah. There are a couple of things I'll sort of say. I had old mentors told me one time, if you can show the data, you'll find the dollars. And so one thing that is remarkable when you look at this field of retail-based nutrition interventions, especially rigorous trials, is the absence of data. This provides that data. So this is something new for payers to look at and really sort of say, okay, here's something we think works and something that we can deliver in communities. And then in terms of what is going to be happening in terms of the cost maybe to the participant, well, we know retail-based care is cheaper just right out of the gate. That's one of its big advantages. And certain things like home delivery are actually, there's price deflation in it. So if you sort of look at the industry, home delivery used to cost this much and it's slowly going down. And my personal belief is that retailers are not going to be able to charge for home delivery at all in the future because of competition. And that, of course, benefits the patient, especially those low-income patients who you're speaking of, who may not have adequate access to grocery stores in their communities, or may not be able to shop there because of medical limitations.
Well, hopefully, the data will continue to accrue in that regard. So what are your personal next steps in terms of additional studies you might have in mind?
So I think this could go a couple ways, and I just, for the audience, I think the big thing is this is sort of a call to action for researchers anywhere in the world to partner with retailers to really build these types of collaborations, to do their own work. For me, I think it would be interesting to see, after we look at SuperWIN and we slice and dice, we see where we can cut the fat, as well as enhance the efficacy of the interventions, and then test it on a larger level for potentially longer period of time to see how long these dietary changes last, but then also to see how downstream health outcomes can be affected. Of note, because we partner with our primary care network in this, we do have full cost and medical utilization capture in this trial. And that will be something that we look at. And there may be some interesting findings there. And part of the reason we partnered with them was we wanted to show that these types of services can be delivered in an integrated care manner. Nobody wants more fragmentation. But the reality is, when you look at the SuperWIN results, you will find that this is a thing that could partner with your primary care clinic and then again support the needs of value-based care sort of advancements.
Well, I hope that is where we evolve to.
Yeah.
So thank you again for leading to such an important study, and that was a fun conversation.
Thank you. Lots of great science at this conference.
So signing off for Medscape, this is Dr. Michelle O'Donoghue.